Thank you very much, sir, for your kind introduction. And at the outset, I would like to thank Dr. Pradeep Kaur and the organizers for the kind invitation and hospitality. It was very educative for me to be here for the last 2 days to learn about what is going on particularly in the area of control of infectious disease. Because in cancer control, we work in silos. It is not intentional, but at the same time, cancer is a very peculiar disease. It is several diseases, and each one requires a different approach, and it is probably the most resource-intensive disease that you will ever come across. The problem with cancer is in suffering, as well as the enormous healthcare costs it involves. And in fact, the health service departments throughout the world spend anywhere between 10 to 20% of their resources on cancer. So this is the real issue with cancer. Can I have the slides, please? Yeah. So in the next 30 minutes or so, I would like to sort of spend some time with a particular focus on India, because India and China are major contributors of disease burden across the world, and what we do will have a great bearing on the global burden of cancer. Cancer control is defined as any action. It is a multi-sectoral action which target reducing the number of cases and cancer deaths. This is very important, reducing the incidence and mortality, improving survival and quality of life. The single most important outcome that we talk in cancer is how a person survives and what quality of life he has. And several cancers present in advanced stages, so palliative care is very important. And WHO had a major role in making palliative care an important aspect of cancer control. But in many countries, including India, in many regions of India, palliative care is least available. And the most difficult thing in cancer control is improving the cancer healthcare infrastructure and resources, because it is very resource intensive. It requires investments in terms of surgery, not only simple surgery, complicated surgery. It involves investments in radiotherapy, which is technically highly advanced. You can sink money into that unless you properly plan it. And medical oncology and hormonal therapy, there are so many agents. That is another area. Unless one is not careful, we will waste a lot of resources. Then finally, how do we finance it? Because this is a major issue. Unless countries which are very clever, like Thailand, Turkey, and those places who have introduced universal health care and manages beautifully the cancer, not only cancer healthcare costs, but healthcare costs in total. We have to really think about how do we assure financial safety. At the moment, one of the worst outcomes in cancer is the household debts, the catastrophic expenditure, and many households become pauper. And then ultimately, surveillance for monitoring and evaluation of what is really happening, which cancers are increasing, decreasing. Are we really making a dent in mortality reduction? Are we improving survival? Are we reducing suffering? India, fortunately, one area we have a lead is in cancer information, thanks to the far vision of people like Dr. Usha Luthra in ICMR, and those times the doyens in cancer control, Dr. Krishna Nair, Krishnamurthy, Dr. Krishna Bhargava, Dr. Jusawala, P.B. Desai, and people like that, who had the vision to introduce the National Cancer Registry Program, which has several cancer registries across India, particularly in southern India and eastern India and western India. The Indo-Gangetic plain is a big gap there, like for anything in India, our statistics is pulled down by this region. And they give a very good handle on cancer patterns in this country. In addition, the Tamil Nadu government has introduced the first statewide registry beginning 2012, which is documenting very important data for Tamil Nadu. And in fact, this is one of the most efficiently run registries, along with the Madras Metropolitan Tumor Registry, the Coimbatore Dindigul Ambalikai Cancer Registry. The Tamil Nadu State Registry is a major investment that Tamil Nadu government has made, and it is very efficiently run. And this will be a major data source for linkage in future to assess cancer control, what is really happening in the state. And if you see, based on the data, this is much more real, much more precise. India accounts for about 1.2 million new cases and about 784,000 cancer deaths. And at any given time, we need to care for almost 2.25 million prevalent cancer cases. And then our pattern is very, very interesting. You have breast cancer, oral cancer, cervix, lung, stomach, colon, and the hematolymphoid neoplasms, leukemia and lymphoma, where the healthcare costs are enormous, which require a very sophisticated approach in its control, and where we have least understanding of the etiology. And all this account for about almost half of our cancer burden in India. So focusing on them will have a major impact. And among men, oral cancer continues to be a major cancer. Lung cancer, fortunately, we have a stable trend for lung cancer. I will come to that in a moment. Then we have stomach cancer, colon, esophagus, which together account for 45% of the cases. And in the case of women, both breast cancer is #1 cancer in the country now. About 162,000 cases where we don't know how to prevent breast cancer. Breast cancer is on the increase. And it is important, the major control approach is early detection and managing appropriately. So the Tamil Nadu State Cancer Registry started in 2012, which is being run by the Madras Metropolitan Registry and Cancer Institute in Chennai, Dr. Swaminathan and colleagues, is a major investment in the state, and it shows a very clear pattern. About 64,000 new cases in 2016, and about 35,000 cases in women. So breast, cervix, oral, stomach, large bowel essentially reflects the national data here. And this will serve a very important function of linkage with whatever interventions Tamil Nadu government is doing, provided you use the data. This is the big thing. Fortunately, our cancer rates are lower than many Western countries. It is real. If you take the age-specific rates for age trend, each age factor, the incidence rates are lower. And there are several reasons for that. Our rural rates are almost half of the urban rates. There are several reasons for this: physical activity, our dietary patterns, and things like that. So maintaining some of our traditional lifestyle is very important. India is changing. India is rapidly changing. Overweight is becoming a major problem. And then we are seeing an increase in the incidence of cancers which are related to less physical activity. We don't walk anymore. We have two-wheelers. We don't have walkways. We don't have the infrastructure to support physical activity. These are major investments which are made by countries like Netherlands, Nordic countries, which we don't do that. And our patterns, dietary patterns, are also very interesting. So some of our traditional things we need to keep. And if you focus on the major risk factors, tobacco is responsible for almost a third of cases in India. So tobacco control is something which will be a major investment. And in tobacco, we have both smoking and chewing, because the entire world concentrates on smoking, but South Asia, we have a major burden of chewing tobacco, chewing areca nut, all these mixtures, the coming in small sachet, and where our control mechanisms are failing. And 75 years after independence, we do not have an alcohol control policy, and governments are the major sellers of alcohol, and alcohol consumption is increasing in this country, and alcohol-related cancer morbidity and chronic disease morbidity is not very well investigated yet. Physical inactivity, overweight, obesity, and air pollution is beginning to be an important problem in this country. Particularly in northern India, the entire northern belt is affected by high levels of air pollution, which will have a telling impact on pulmonary health. Particularly, it might have we have an increasing incidence of adenocarcinoma of the lung, which may be related to this. Then, of course, human papilloma viral infection and Helicobacter pylori infection. And our prevalence of hepatitis B and C is still on the lower side, but fortunately, the universal immunization program has already implemented vaccination. But there are major gaps here. For smoking control, we have a partial success. In fact, the smoking prevalence is coming down in India, and our lung cancer rates are remaining, which is one of the major indicators of tobacco control. But we have failed in the domain of controlling chewing tobacco and chewing areca nut. It escapes all regulatory procedures. And our newspapers come with front page advertisements for pan masala and all types of things. We have a miserable failure in controlling chewing tobacco and chewing areca nut. As I already said, there is no alcohol control policy. Hpv vaccination, which is considered to be one of the best buys in cancer prevention by WHO, is not part of universal immunization program. It went an information assault and misinformation in this country, which put back our introduction to many years behind. And in fact, large countries in Asia, China, India, and Indonesia is doing very badly in not introducing human papillomaviral vaccine, which is one of the best buys. We'll come to that in a moment. And finally, the inadequate infrastructure. We don't have walkways. I think crossing the road is the most dangerous thing in India. Walking in the road, we can be knocked off. And there are no cycling provisions. There are transportation. Physical activity is one of the important components of physical activity. WHO would say one need to have 8,000 steps a day to keep a healthy lifestyle. And we don't have the means to do that. Recreational grounds are disappearing. Tobacco control. We are one of the largest producers and consumers of tobacco, 275 million, 27.5 crore tobacco users. And out of which, 16 crores of smokeless tobacco users. And we have a reasonable compliance for FCTC, particularly which has an impact on smoking. So smoking rates are either stable in some regions or even declining in many regions of India. That's a good news. But chewing tobacco is on the increase. In the case of lung cancer, the male lung cancer rates are remaining stable, if you look at our cancer registry data, but it is increasing in women. This is something which we need to focus on before it reaches an epidemic proportion. And pan masala, if you see the business reports for pan masala, this is supposed to be one of the most promising business propositions in this country. Currently, its market value is about 35,000 crores, and it is projected to double by 2023 to almost 60,000 crores of business. So it is immensely popular. It affects the lower socioeconomic strata, and it has already a telling effect on oral cancer. The oral cancer rates are increasing in young people in this country. This is very evident. In fact, now you see pan masala, chewing tobacco-related oral cancers in the third decade and fourth decade, very aggressive cancers. And the prophylactic vaccination, Hpv vaccination, is the best to buy. The recommendation is IM injections, 2 doses, 6 to 12 months apart for those between 9 to 14. And the secondary target age group, 3 doses in a 6-month period, and immunocompromised girls. The recommendation is there. It is highly recommended by WHO. But there is a huge confusion about this in this country because fortunately our cervix cancer rates are declining at a rate of 1 to 3% per annum. This is necessarily a good thing. When a disease is declining, when you have a very specific intervention, the pace of reduction can be substantially augmented. In fact, India has the feasibility to eliminate, which is the latest WHO call for cancer cervix, elimination of cervical cancer. So we have the feasibility to eliminate cervical cancer, particularly if you take the state of Kerala, where the cervix cancer rate is 1/4 of rest of India, about 6 to 7 per 100,000. In Kanyakumari district in Tamil Nadu, it is about 6 per 100,000. I mean, these are places one can eliminate cervical cancer in a reasonable period of time, provided we make investments in primary prevention as well as secondary prevention. And in fact, there are major cancer centers in this country, major oncologists in this country who would say, oh, don't recommend this, and they are very close to policy making. But fortunately, there are states who have implemented this. You know, a disease is declining doesn't mean that it will not increase in future. In Mao Zedong, China, cervix cancer reached incidence rates like 5 per 100,000. HPV prevalence was less than 5%. Now the HPV prevalence is around 20% of the population, and cancer rates are increasing, rapidly increasing. So social changes. So this is also we need to keep in mind. And there is very exciting data on the dosage. Even a single dose is as effective as 2 doses and 3 doses. An Indian study as well as a study in Costa Rica are very consistent in showing this for the bivalent and quadrivalent vaccine. So this can be a recommendation in the near future which will make logistics of vaccination much simpler. Unfortunately, 2 states, Punjab in 2 districts and Sikkim in the entire state, have launched human papillomaviral vaccination using their own resources with very good participation and very good safety profile. Safety was something which was questioned in this country. We have substantial information from India now. This is as safe as an injection tetanus toxoid or any other vaccine. And another good news is there is an Indian vaccine around the corner. The Indian vaccine has completed phase 1, phase 2 trials, and the phase 3 trials will commence now. The Indian drugs regulator has accepted that if it shows equivalent immune response to that of the quadrivalent vaccine available in the market, they will license it. That means this vaccine could be available in the market next year. That is going to substantially change, like in hepatitis B vaccination, in a substantial change in the way the affordability of the vaccine and the applicability of the vaccine in public health services. And there are 9 vaccines being developed in China, and one of the vaccine is very close to licensing. So these are important developments. Okay. Now, turning the plate now, the second approach, early detection. About 80% of the cancers are diagnosed in advanced stages. In advanced stages, whatever you do, heroic medical oncology, heroic chemotherapy, heroic radiation therapy, doesn't matter. In head and neck cancer, as soon as the lymph nodes are involved, 5-year survival drops to less than 20%. In breast cancer, stage 4 breast cancer is survival probability, 5-year survival probability is less than 20%. So we have definite data. And all this, you take head and neck cancer, all the improvements, all the so-called advances in treatment have not made any difference. There are 2 approaches in early detection. Screening is detecting disease in asymptomatic people, looking for very early disease, and it will require considerable healthcare infrastructure, human resources, committed providers, and finances, and a very robust healthcare system. And in India, believe me, it is not possible. It is not feasible. There are certain states like Tamil Nadu which have implemented, but they have made substantial vertical investments in providers, quality assurance, and consumables, and all those things. And Dr. Gerard Selvam is here. We will learn from him, how much investments that Tamil Nadu has made in introducing screening programs for cervix, breast, and oral cancer. But the strategy which has worked all along for cancer is early diagnosis in symptomatic people, increasing the awareness, increasing the healthcare capacity to make basic diagnosis and to have an adequate referral, which makes an enormous difference. Even before screening was introduced in Western countries, there are substantial gains in 5-year survival and mortality reduction because of early diagnosis. This is which is very important. This is to schematically, so WHO is now a major proponent for early diagnosis as an early detection procedure for low and middle income countries, because the existing healthcare system has the capacity, or with minimal augmentation of the healthcare system, one can support an early diagnosis program. This is one of the major studies in Dindigul district in Tamil Nadu, which showed a single round of VAA screening and treating people with ablative or excisional procedures for precancerous lesions reduced incidence by 35%. And even after 20 years, the protection in the population remains. And this has been a major policy changer in many countries in Africa, this particular study. And following this, late Dr. Padmanabhan in Tamil Nadu, took the early steps to introduce the cervix cancer screening in the Tamil Nadu Health System project. So some of the very important evidence-based approaches are very important, but in this country, the local research is not taken very much into consideration. And in fact, Tamil Nadu is only state in the country which has taken a lead over other states, in introducing early detection for cancer cervix, breast cancer, and oral cancer. And there is substantial amount of data. This can be linked with the Tamil Nadu Cancer Registry. The quality assurance can be looked into. There are several things which we can do. This is a large database. People are looking for large data, and you have the large data at your doorstep. Then another landmark study in Usmanabad district in Maharashtra showed a single round of HPV testing can reduce the incidence and mortality from cervix cancer by 50%. And that protection stays for long. And for 10 years, those people who have a negative HPV test do not develop cervical cancer. They have very high negative predictive value. In fact, many countries are switching over from cytology to HPV testing as the primary screening approach because this is the most efficient. So in India, a judicious combination of vaccination plus HPV screening of women between 30 and 39 years as recommended by WHO can lead to potential elimination of cervical cancer. Now coming to breast cancer is increasing. It is increasing by 3 to 4% per annum. In all across India, it is increasing. This is one disease, including rural areas. It is increasing. And the way to control breast cancer, we cannot introduce mammography-based screening because it requires substantial resources. A mammography screening unit will need 2 mammograms, 2 radiologists or 1 computer-assisted detection, and about 8 nurses, a surgeon, and a pathologist, and it's not possible. That infrastructure we cannot create. But on the other hand, breast awareness, making people aware about breast cancer and once in a while palpating the breast, and if there is an abnormality and seeking attention, medical attention is the way to go forward. And once the medical advice is sought, prompt referral is very important, and via the health service can provide what we call as triple diagnosis. Triple diagnosis consists of an expert clinical breast examination by a breast surgeon or an oncologist or an experienced doctor. And if he or she feels something abnormal, having a diagnostic imaging, it is not screening imaging, diagnostic imaging, particularly ultrasonography in less than 40 years of age, 45 years of age, and diagnostic mammography in more than 45 years. And if those imaging modalities are highly suspicious, then one can go for tissue proof, either with fine needle aspiration cytology or excision biopsy. But treatment is very important in breast cancer. And in breast cancer, the basic diagnosis with hematoxylin and eosin is very important for cancer. That's our cause. But immunohistochemistry is very important to divide breast cancers into estrogen receptor dependent breast cancers, non-dependent breast cancers. Go a little more further, then you can have HER2 new receptor and all those things. But that will all depend upon healthcare resources. The minimum one can look into is, whether the breast cancer demonstrates estrogen receptors. Then they are hormone dependent, so hormonal therapy will benefit them. So there are basic treatments which are very important in breast cancer, which has completely changed the prognosis in breast cancer. And in fact, in Kerala, as such, breast awareness is much higher. And in fact, if you look into the 5-year survival approaches around 80% overall. And in stage 1 cancer, the 5-year survival is almost 96 and 97%. It is because of very high breast awareness and good access to treatment and follow-up care. Breast cancer increases, colorectal cancer increases. 15-year time period. And colorectal cancer is increasing in this country, which was rare, but it is increasing. And we need to look into, and we need to increase capacity for screening, capacity for endoscopy, because endoscopy is a very important component in early diagnosis, but at the same time concentrate on primary prevention, healthy diet, physical activity, and alcohol control. As I said earlier, oral cancer is increasing in young people predominantly because of chewing tobacco and chewing areca nut. So we need to do something. And oral cancer screening is highly effective. And in fact, it can substantially reduce incidence and mortality, particularly focusing on tobacco users and alcohol drinkers. And repeating it once in 3 years or 5 years can substantially reduce incidence and mortality. And then finally, cancer care. Unless you care for symptomatic people, a program fails, and cancer is highly symptomatic. It's a dangerous disease. With the exception of differentiated thyroid cancer and skin cancer and indolent prostate cancer, all cancers kill. They have an aggressive natural history. And they spread. Metastatic cancer is highly symptomatic. The pain from cancer is tortuous. So cancer care is an important component. And this is one area there is a great heterogeneity across the country. Some states have reasonably well-developed infrastructure, but many states do not have. And access to care, in Indo-Gangetic Plain, the states, I wouldn't name them, is pathetic. And these people have to crowd in All India Institute of Medical Sciences, or Christian Medical College in Vellore, or the Tata Memorial Center and lie down in the roads to seek treatment. And this is a miserable state after several years from independence. And healthcare financing, to be ornamental, we can say, is evolving. We need to introduce universal healthcare very rapidly. And there are good lessons which can learn from, how Thachin Shinawatra introduced universal healthcare in Thailand in a 10-year period. What Costa Rica took around almost 70 years, Thachin was able to do it in Thailand in about 10 years' time to reach universal healthcare. So there are several lessons. And some of the interesting things which have happened is to improve the level of infrastructure, human resources, and uniformity and quality assurance. The National Cancer Grid is a very important development, which is led by Tata Memorial Center. And it has a representation by more than 150 centers. And this will have a positive impact. And currently, 155 centers are participating in the National Cancer Grid. And Ayushman Bharat, I hope this is a first step towards universal healthcare. But this is an entitlement-based scheme where the government is the payer, is not predominantly the provider. And this is the dilemma here. And the resources which are required, for managing complicated diseases like cancer, particularly for hematolymphoid neoplasms, it is not possible. So very recently in November, I don't remember, 2019, the Parliamentary Standing Committee on Science and Technology, Environment and Climate Change recognized the gross inadequacy of cancer care in India, and they entrusted with the Tata Memorial Center of the Department of Atomic Energy to the establishment of a hub-and-spoke model for cancer care with 30 hubs, which can manage very complicated cases, and 120 spokes under the technical leadership of TMC of DAE. We have to wait and see whether it works. Or, in a large country like India, we have to centralize everything under one institution. But it is an important recognition of the inadequate infrastructure. I hope this leads to something. And finally, among all the Indian states, Kerala has probably the best cancer control at the current moment. Globally, I would say Australia has the best global cancer control. Anywhere in the world, very comprehensive, followed by countries like Canada, Oman, and places like that. And in India, at the moment, the health system response for cancer is the highest in Kerala. And this is because of the commitment of successive governments to invest in infrastructure. And in fact, if you see, a patient need not travel for more than 50 kilometers to reach a cancer treatment facility. And access is possible. There are many, many schemes through which the treatment can be ensured. And there is good follow-up care. There is extension services. And the 3 regional cancer centers, the Regional Cancer Center at Trivandrum, where it's my alumni, and I'm very proud that I'm a product of the Regional Cancer Center, Trivandrum, and the Cancer Care Center in Cochin, and the Cancer Center in Malabar, have really taken the technical leadership to provide the public health support to the cancer program in Kerala. And this is a very important thing, because this is not a desk job. Cancer control is not a desk job. There is a need for a strong technical support by good people who have a public health concept. And if you ask me in Tamil Nadu, the possibility that Dr. Gerard Selvam could remain for many years has a major impact on the cancer program, on the NCD program in the state, because it's not transferred. There are several things. So I would pay a tribute to the state, to making possible for a common man to access treatment, where they need not rely on expensive private health care. And in fact, the government should be taking the responsibility to introduce the quality and the investments in public health system so they become competitive to the private health care, so they balance out each other. This has to happen in this country. And finally, cancer control research. There is very important cancer control research in this country. Few committed people across India have made some very important cancer research outcomes, which are increasingly adapted in healthcare policies in other countries than in India. And in fact, this is a very sad state of affairs, and I'm sure this will be the same trend for others. I'm not lamenting here, but at the same time, I'm focusing on a very important thing. This is my last slide. And thank you very much for your kind intention. So it was attention, and it was sort of fragmented presentation, but I wanted to show some glimpses which are relevant to the Indian cancer control situation. Thank you.